I would also request our panelist, Professor Noor Mohammad Memon, Professor of Medicine, Muhammad Medical College, Mirpur Khas, to kindly join us on the stage. And now that the stage is set, we can start off with our program. And I'm once again very thankful to all of our panelists and our chairpersons for being here with us. To start off with the first lecture, to talk about something which is very common and something that we encounter in our clinical practices almost every day, cirrhosis and its complications, we have Professor Aftab Mohsin, consultant physician with a special interest in liver and GI diseases. He is also a senior vice president of Pakistan Society of Internal Medicine, and he has also remained principal Rashid Latif Medical College, Lahore. Please put your hands together for Professor Aftab Mohsin.
ये प्रेजेंट नहीं होगा Bismillahirrahmanirrahim. It's indeed a pleasure to be here this morning and represent Pakistan Society of Internal Medicine. I am really delighted to have so many august panelists and chairpersons in the session, and there are people sat in the audience also. So thank you very much for being here this morning. I have chosen a topic that is very common, cirrhosis, its complications, and choosing sides. The importance of this choosiness is based on the treating physician. And I will highlight why is this so important. When a person, now in year 2021, in the standard of care of diabetes, it was published that we should call people who present with diseases as persons, not as diabetics or patients, but person with cirrhosis. So we have been hearing about this for a very long time, and this choosing sides is choosing sides on behalf of the person who has presented. What is at the heart of this disorder is the liver lobule, which is made up of many of such units. And there are very important cells in this lobules, and there are Kupffer cells and stellate cells. Normally, Kupffer cells are the tissue macrophages, and they are activated once there is inflammation. There are two ways that our body decays or dies, and those are so simple, and I will highlight them. So once inflammation sets in, Kupffer cells and stellate cells are activated. once they remain activated for a long time, their control becomes lost and there is a lot of cross talk. और जब क्रॉस टॉक होती है, चाहे वो असेंबली हॉल में हो रही हो ऑफ पाकिस्तान नेशनल असेंबली या क्लासरूम में हो रही हो, इट इज़ बैड for the environment. Similarly, the crosstalk that starts taking place because of either the inflammation or the other process that is taking place, it's bad for the liver and the result is fibrosis. So, though kya pathogenetic mechanisms hain which cause liver injury, first is known as holopathogenesis, and that's inflammation. The second is apoptosis, programmed cell death. We are all programmed to die. Previously, it was thought that cell death is a degenerative process. It's a decaying process. But now we know from science that this is also programmed and is called apoptosis. Even Ghalib was aware of this. And he said, and I quote, मेरी तामीर में मुज़मिर है एक सूरत खराबी की, हेओला बरके खिरमन का है और जिस्म जो है वो आग का बना हुआ है. So look at this, even he was aware of this, and what causes worse outcome out of everything in the liver. So होना क्या है, either there is apoptosis or inflammation that leads to liver damage, but what is the leading cause or what are the leading causes? First, I have put down NAFLD, non-alcoholic fatty liver disease. The new name is metabolic associated liver disease or fatty liver disease, MAFLD, because non-alcoholic के बारे में लोगों ने वेस्ट में कहा कि इससे लगता है कि इतना सिग्निफिकेंट नहीं है. So the new term is MAFLD, metabolic associated fatty liver disease, and this has become the commonest cause of liver disease throughout the world. However, in Pakistan, hepatitis C remains the major cause of liver cirrhosis and liver injury, but very soon NAFLD or MAFLD will become number one. Then is alcohol and other toxins. I have only mentioned alcohol, but this alcohol also represents other toxins and other drugs which are either herbal or allopathic. So all toxins together are clubbed with alcohol, and then there is this low-lying hepatitis B virus also, and we have had significant improvement in prevalence of hepatitis B thanks to the vaccine that is available. Then there are other causes, and one of the common ones is autoimmune hepatitis, and we see that very frequently these days. Then hemochromatosis, primary biliary cholangitis, Wilson's disease. So these are the major causes. There are many more, but I will skip those. So once we have the underlying disease, then there are other factors which contribute to disease progression. So this is multifactorial. There are many factors. Out of these, there are genetic factors. There are certain genes that are activated. हमारी genes तकरीबन सबकी एक जैसी हैं. 99.9% genes are same in everybody, but not all of them are activated in everyone. If a disease which is signified by activation of one gene is prevalent, then probably that gene has been activated. So what contributes to that activation of gene is a very significant part of medical studies, and that is known as epigenetics. The effect of environment on the genes that leads to expression of those genes and then the disease. And now we know that there is another organ which is there in the human being, and that is the microbiome. The total number of microorganisms that live in us is microbiome. It's not only their effect by what they produce, it is also the effect of their genes on us. So this organ, which is termed as microbiome, lives largely in the GIT, but also on the skin and other linings of our body, and has a very significant effect. और आपने सुना ही होगा कि अब फीकल ट्रांसप्लांट करते हैं, जिसमें एक हेल्दी पर्सन का फीसिस लेकर we put that in the cecum through a colonoscope, and then the person having inflammatory bowel disease or IBS may have significant improvement. It's such a simple procedure, and a lot of data is now available on changing it with a very simple colonoscopy and putting a solution which is composed of shit from a normal person. When a person with cirrhosis comes, most of the time they are there because of underlying infection, and it's called sepsis, then toxins, and then our lifestyle and age. That also contributes to disease. Lifestyle has become very significant, and I have dedicated a slide to lifestyle, which I'll come about later on. So what are the outcomes? Once a person lands with cirrhosis, either they come with decompensation, and that is manifest clinically. जब मरीज को मैं राउंड पर देखता हूँ तो आई आस्क माय यंग रेजिडेंट्स कि आप क्या बता सकते हैं इसके बारे में, तो आई एक्सपेक्ट कि दे टेल मी क्लिनिकली ऑन द बेड साइड दैट दिस पर्सन हैज़ decompensated liver disease or compensated liver disease. Cirrhosis, जैसे हमें के बताया गया था, is a histological diagnosis, but decompensation is a clinical diagnosis. So अगर किसी को confusion है, encephalopathy है, तो you can make a diagnosis of decompensation. Hepatorenal shutdown, अगर urine output कम हो गया, तो you can make a diagnosis of decompensation. Upper GI bleed किसी भी तरह manifest हो रही है, चाहे मलीना है, hematemesis है, या दोनों हैं, या unexplained anemia है, then you can make a diagnosis of upper GI bleed. Ascites and edema, and then HCC. Only one thing is more dreadful than HCC, and that is death. But Socrates said, and I quote, that may be the greatest of human blessings. And when he was given, unquote, he said that death may be the greatest of human blessings, and I truly believe that. And when he was given that poison to be drunk, he said that I am going to drink this and die, but I don't know whether I am the loser or the people who are making me drink this. They are at loss. So come to clinical medicine, person has come and you have encountered the person. इसके 3 components होते हैं. You take history, you do physical examination, and the last and the most important is that we make a clinical judgment. मैं यहाँ पर कहता हूँ कि हमारे जो young doctors हैं और कुछ not so young, they make decisions reflexly. That is not a good physician. The sign of a good physician is that you make a thoughtful clinical decision about the patient or the person. So what decides that you are a good doctor or a great doctor? It's very hard to become a great physician. There are great physicians, but the first thing a great physician will do, which others may not do, is give right to decide to the person who has come with the problem. Autonomy, the right to decide, rests with the patient, not with us, not with anybody else, but with the patient. And whatever decision you take, you should take it in light of current best practices or current best available evidence. PSIM का बहुत नाम हुआ, इधर सब लोग जो हैं, they represent PSIM in one way or the other. and we have held 3 international conferences. Our 4th one is going to be in Lahore, and I'm going to extend invitation on the last slide to all of you. And all 4, the theme has been evidence-based medicine apnao. And the reason is that your decisions should be according to the current best evidence. फिर excellence है और skillful होना है. Ethics अलबत्ता सबसे important है. उसमें beneficence भी आएगी, attitude भी आएगा, being empathetic. बहुत अरसा मैं जब आया पाकिस्तान यूके से ट्रेनिंग कर आफ्टर माय MRCP, I was trained in Nishtar Medical College Multan, but then I went to UK for MRCP. मैं हिस्ट्री टेकिंग और फिजिकल एग्जामिनेशन और क्लिनिकल इनकाउंटर का मेन ऑब्जेक्टिव यही समझता रहा कि डायग्नोसिस बना लिया है तो ये है, और फिर ट्रीटमेंट सही कर दी तो ये है एक अच्छे फिजिशियन का खासा या खसूसियत कि सही डायग्नोस कर ले. लेकिन अब लेटली आपके पास जब तक आप मरीज़ देखते हैं वो डायग्नोसिस ऑलमोस्ट ऑलवेज हैज़ बीन मेड बाय आवर वेरी वर्दी competent young colleagues, and because so many investigations are available. When we were medical students, getting an ultrasound scan done was an uphill task. अभी जब हम सुबह जाते हैं तो अक्सर CT scan भी हो चुका होता है. So diagnosis is not that big an issue, and it's not the main objective of the physician. The main purpose of you meeting with the person with disease or disorder is to have a meaningful patient relationship. इस पे बेस करेगा आपका सारा कुछ कि आपका relationship कितना important है, and that will determine or drive the outcome of the person. वो कहते हैं ना, उनके देखे से जो आ जाती है पर मुंह पर रौनक, वो समझते हैं कि बीमार का हाल अच्छा है, मगर वाकई ही डॉक्टर को देख के मरीज़ के मुंह पे रौनक आ जाती है और उसकी आउटकम बेहतर हो जाता है. So little about lifestyle. There are 6 pillars of lifestyle medicine, and I must acknowledge कि जब हम आ रहे थे, we were traveling from Karachi to Hyderabad, तो मैंने डॉक्टर सोमिया को बहुत मसरूफ़ रखा कि जी मेरी स्लाइडें जो हैं बहुत बेरंग हैं, इनमें कुछ रंग डालें. तो शी डिड ऑल दिस. द कंटेंट इज़ माइन. कहीं कहीं इन्होंने उसमें भी मेरी मदद की है, लेकिन ये जो बेहतर नज़र आ रही हैं, आई होप कि यू विल आल्सो फाइंड देम बेहतर. तो शी ऑलवेज फोकसेस ऑन एक्सीलेंस. तो ये थैंक्स टू डॉक्टर सोमिया, थैंक यू. सो देयर आर 6 पिलर्स ऑफ लाइफस्टाइल मेडिसिन: डाइट, एक्सरसाइज, sleep, social connectedness, avoidance of substance abuse and tobacco, and stress management. इसमें सबसे जो अहम चीज़ है जो आउटकम डिटरमिन करती है वो इन 6 में नहीं है, वो इन 6 का महवर है, वो इन 6 का नुक्ता है जिस पर वो बात कहते हैं ना ख़त्म होती है. And that is belief, positive faith in your physician. Belief that I am going to get better. So that comes from a meaningful, purposeful physician-person-patient relationship. So ये मैंने बता दिया कि ये decompensation होती है तो clinical diagnosis है. HCC और death, they are dreadful. So अब HCC को मैं यहाँ जिक्र करूँगा. बहुत सारे मरीज़ अब आते हैं HCC के साथ. आज से 10 साल पहले the commonest cause of admission to tertiary care hospitals was decompensated liver disease. That is no longer true. The reason is that most of hepatitis C was spread in late 70s or early 70s, not late 70s, when smallpox vaccination was going on. And it is thought that that was responsible for rampant spread of hepatitis C in Pakistan. हमें भी वो टीके लगे थे चेचक के, और 74 में पाकिस्तान claimed smallpox free and was the 3rd or the 2nd last country जो कि smallpox free हुई थी, and then the world was declared smallpox free. HCC is a result of that vaccination which was gone wrong, और HCC और हेपेटाइटिस सी इन इजिप्ट जहाँ के प्रेवलेंस सबसे ज़्यादा है, उसकी वजह बनी थी बिलहार्जिया की ट्रीटमेंट, शिस्टोसोमाइसिस की ट्रीटमेंट, एंटी-मनी इंजेक्शंस, एंड दैट हैज़ आल्सो बीन प्रूवन बियॉन्ड डाउट। हमारे है 7%, इजिप्ट में है 15 से 16%, बट दे हैव एरेडिकेटेड हेपेटाइटिस सी in 2019 because of an excellent program, but हमारे अभी बढ़ ही रहा है. It is HCC is the second most fatal cancer, and the most fatal one is the one that killed Steve Jobs. It's the pancreatic cancer, and he for a very long time wanted to treat it with his mind power, but unfortunately wasn't successful. HCC is the commonest cancer in adult males in Pakistan, and its causes are same as they are for liver disease, and your treatment depends on tumor size, burden of the tumor, and tumor location. And what we use is BCLC staging. मैं इस पे थोड़ा सा फोकस करूँगा. बार्सिलोना क्लिनिक लिवर कैंसर staging is dependent on these 4 things. I will highlight this because when the person with cirrhosis comes with this, people do one fatal mistake, treating physicians. They will look at the tumor size and location, and they will categorize the person in BCLC stage 0 or A, lekin they will ignore liver function and performance status. Liver function normal hona chahiye in BCLC stage 0 and A, और परफॉर्मेंस स्टेटस 0 होना चाहिए कि हर काम बंदा कर सके. मगर जब तक यहाँ आता है पर्सन, तो यूजुअली वो डीकॉम्पनसेट ही हो चुका होता है, उसके LFTs डिस्टर्ब होते हैं और परफॉर्मेंस स्टेटस सही नहीं होता, तो लोग उसको BCLC स्टेज A में डाल के ट्रीट कर देते हैं, और फिर वो डीकॉम्पनसेट होके पेशेंट पासेस अवे, वो फौत हो जाते हैं. और पोर्टल प्रेशर भी स्टेज 0 और A में नॉर्मल होना चाहिए, which is less than 7 kilopascals, and you can get it done easily now on a shear wave elastography. तो परफॉर्मेंस स्टेटस की ये हैं कैटेगरीज, इसको मैं इग्नोर करता हूँ. और स्टेजिंग करते हुए 4 चीज़ें देखनी हैं, सिर्फ ट्यूमर साइज नहीं देखना, लिवर फंक्शन देखना है, परफॉर्मेंस स्टेटस देखना है, और उसके बाकी फंक्शंस भी देखने हैं. MEL score and Milan criteria I will ignore because that's not, and this is BCLC staging की आगे ये आपने ज़रूर देखना है. इसके ऊपर आपने डिसीजन लेना है जब पर्सन विद सिरोसिस विद HCC आए, और उसको कैटेगराइज करना है 0 A B C D में, और फिर ट्रीटमेंट ऑप्शन देनी है. मैंने ये देखा है कि चूजिंग साइड से मेरा मतलब है कि सिर्फ साइज़ पे आप A और 0 या B बना देते हैं, और उसको ट्रीटमेंट वो ऑफ़र करते हैं जैसे लिवर रिसेक्शन है, या उसकी एब्लेशन कर देते हैं और बंदा जो है फौत हो जाता है. सो दिस इज़ इम्पॉर्टेंट दैट ऑल योर डिसीजंस आर बेस्ड ऑन करंट बेस्ट एविडेंस. Now, certain other cases which are very common. Middle-aged lady with drowsiness has stage C liver cancer and is brought to ER. She is admitted in the hospital, and I see those patients regularly in my clinic. वहाँ पे उनको बताते हैं जी इनका कैंसर है, ये बहुत बड़ा है, ये नाकाबिले इलाज है. Ultimately क्या होता है? What will a person do who has limited resources? जबकि इलाज भी पूरी तरह मुफ्त नहीं होता. They leave against medical advice. जब मैं गया गुजरांवाला में, I was made principal in 2013, and I stayed there till 2017 when I left on my own. ये मुज़फ़्फ़र शेख साहब बीका राम को भी बता देना, people can leave principalship on their own, और उसमें कोई बड़ी बात नहीं होती, तो इसको बुरा नहीं मानना चाहिए. So it's nothing, ये principalship, VC-ship. हम हर दफ़ा इंटरव्यू में पियर होते रहे VC के लिए, और जिनको मशवरा देते थे माशाल्लाह वो अक्सर कामयाब हो जाते थे, मगर मैं आज तक VC नहीं लग सका. तो एंड आई डोंट फील बैड अबाउट इट. इंसान जो है ना, उसको जो चीज़ उसके पास होती है वही अच्छी लगने लग जाती. तो व्हाट हैपन्स इज़ दैट द पर्सन्स, वो फैमिली जो है बिल्कुल डिसहार्ट हो जाती है, वो मरीज़ को घर ले जाते हैं, 1-2 दिन घर पे भी नहीं देखा जाता, तो दे एंड अप इन अ क्लिनिक विद मी. आई हैव अ क्लिनिक कॉल्ड लिवर क्लिनिक. तो वो मेरे पास उनका पहले कोई बच्चा बच्ची या फैमिली आएगी और वो हमें कहते हैं जी हमें क्या करना चाहिए, और वो कहते हैं हमें बताएं ये हमारा मरीज़ ठीक हो जाएगा या नहीं. तो मैं कहता हूँ बिल्कुल ठीक हो जाएगा, क्योंकि द पर्सन इज़ नॉट डाइंग ऑफ HCC. The person is dying of those causes which has caused decompensation. And HCC is only one cause that cannot be treated, but sepsis can be treated, but dehydration can be treated, but hypokalemia can be treated, but hypoglycemia can be treated, many electrolyte imbalances can be treated, and hypoalbuminemia and malnutrition can be treated. And they cause significant improvement. So what is the first thing I do? I have faith in myself. और जो आपके ज़हन में होता है ना, it gets communicated to the person who is suffering and to the family who is there. पहले अपने अंदर faith लाना होता है. Faith is the most important component of healing. तो आपने कहना है कि ये ठीक हो जाएगा, और फिर आपने उन चीज़ों को देखना है, जैसे इन्फेक्शन है, जैसे हाइपोएल्ब्यूमिनीमिया है, मेल न्यूट्रिशन है, हाइपोग्लाइसीमिया है, उनको ट्रीट करेंगे. एंड लो एंड बी होल्ड पेशेंट्स विल गेट बेटर एंड मे लिव फॉर मैनी ईयर्स देयर आफ्टर विद HCC. एंड व्हाट इज द ट्रीटमेंट? अगर एनसेफेलोपैथी में या ड्राउजीनेस के साथ पर्सन आता है विद सिरोसिस, सो दिस इज द ट्रीटमेंट. पहले उसको L-ornithine L-aspartate दें, लोला, फिर ब्रांच चेन अमीनो एसिड दें. अब एक ब्रांच चेन अमीनो एसिड की इन्फ्यूजन मिलती है. व्हाट आई डू इज सेट अप दैट इन्फ्यूजन एंड पुट 2 ampules of L-ornithine L-aspartate in that and start it on a daily basis. Next is I give ceftriaxone. Ceftriaxone is not a bad drug. It's an excellent medicine. Lekin unfortunately, we have made it bad because of the partial resistance. हमारे unfortunately ये हो रहा है कि we start with meropenem. भाई meropenem पे शुरू हो रहा है. जिना अस्पताल का मरीज जो लाहौर में है, सर्विसेज का मरीज जो लाहौर में है, तो जब नहीं काम करेगा तो क्या करेंगे? So ceftriaxone is not bad, it's good, still works, but you need to give full dose. 80 to 100 milligram per kilogram, 4 grams for adults. And you can give it once a day or twice a day. अगर आप ये डोज नहीं दे रहे तो आप अपने एंटीबायोटिक स्टूवर्डशिप नहीं कर रहे, आप जरासीमों को फेवर कर रहे हैं. And Somia is an expert on this antibiotics stewardship. And the main reason is that we are giving sub-therapeutic doses and expecting therapeutic results. Meropenem नहीं देनी भाई, देनी है ceftriaxone, उसको रखें रिजर्व में. Give rifaximin, lactulose, flumazenil. अभी मैं रास्ते में खालिद साहब से बात कर रहा था, प्रोफेसर खालिद महमूद, चैप्टर भी लाहौर के प्रेसिडेंट हैं. हमारे जी PSIM में ये बड़ा है प्रेसिडेंट. तो जब सारे प्रेसिडेंट बन गए PSIM में, जावेद अकरम साहब हमारे प्रेसिडेंट हैं, हरदिल अजीज, तो मैं रह गया वाइस प्रेसिडेंट. मैंने कहा सर मुझे भी तो प्रेसिडेंट बनना है ना आखिर, तो मैं क्या करूं? तो हमने कहा कि उन्होंने कहा तुम एक वो बनाओ फेलोशिप कमेटी, उसका चेयरपर्सन तुम लग जाओ. मैंने कहा फिर मैं चेयरपर्सन नहीं लगूंगा, फेलोशिप कमेटी का मैं प्रेसिडेंट लग जाता हूँ. तो फिर हमें भी अपनी तस्कीन हो गई. तो अल्लाह करे यही तस्कीन अब इमरान खान साहब को भी मिल जाए और जल्दी वो प्राइम मिनिस्टर बन जाएं, और उसके बाद जो कुछ करना है या नहीं करना वो तो बात की बात है. लेकिन होता यह है कि जब मरीज़ आता है, खालिद साहब प्रेसिडेंट से बात निकली थी, तो वो पहले इरिटेबल होता है. सिरोसिस का पर्सन जब वो डिकम्पनसेट हो रहा होता है, एनसेफेलोपैथी में जा रहा होता है, इन्फेक्शन हो रही होती है, डिहाइड्रेशन में जा रहा होता है, तो इरिटेबल होता है. इरिटेबल जब होता है तो यूजुअली दीज आर मिडल एज पीपल, दे बिकम रेस्टलेस. सो व्हाट हैपन्स? वो घर वाले ही उठा के अद्धी ज़ैनक्स दे दो, अद्धी लेक्सोटनल दे दो. जब हम मेडिकल स्टूडेंट थे तो हमारे रजिस्ट्रार ताहिर साहब वो कहते होते थे कि भाई टीचिंग ये है कि अगर मरीज़ विद cirrhosis, becomes restless, sedate the ward. Don't sedate the patient, otherwise the person will not come out of that sedation and may pass away in the coma. लेकिन अब हमारे पास fortunately flumezanil available है. I don't know how many of you use it. I use it invariably in all my persons who present with portosystemic encephalopathy. NX8 के नाम से available है. 20 ml आपने देना है, 10 ml IV stat, 10 ml in infusion, and many people will rise up. Even they have underlying HCC, लेकिन वो ठीक हो जाते हैं. तो try this. Human albumin, जर्मनी से और बड़ी दुनिया से स्टडीज आई हैं. अगर एनसेफलोपैथी को ट्रीट करना है तो जो सबसे इम्पोर्टेंट दवा है वो एल्ब्यूमिन है. द डोज इज़ 1 ग्राम पर किलोग्राम. फिर प्रॉपर डोज तो देना भाई. हम देते हैं 50 ml की शीशी लगा दो, ना इधर के रहे ना उधर के. 80 ग्राम डोज है तो 400 ml की बोतलें इनिशियल डोज. तो लिवर किडनी सब खराब हो रहा होता है, सेडेटिव्स मिल रहे होते हैं. और ये मैंने बता दिया है. अगर पेशेंट आया है विद अपर जीआई ब्लीड तो उसको ट्रीट करना, मैं उस पर नहीं जाऊंगा, वो बहुत ही सिंपल है, आजकल हर जगह यूज़ हो रहा है. ये इसको मैं थोड़ा सा हाईलाइट करूंगा. पर्सन विद सिरोसिस बिकम्स हैविंग ग्रॉस असाइटिस. वो ठीक ही नहीं हो रहा, असाइटिस बढ़ती चली जा रही है. एक मरीज आया 3 दिन पहले कि जी 14 मरतबा इनका पिछले 3 महीने में टैप हो चुका है. तकरीबन हर हफ्ते जाके 5-6 लीटर पानी निकलवाते हैं. तो मेल न्यूट्रिशन को भी एड्रेस करें. एंड समटाइम्स आई हैव सीन दैट गिविंग हाई प्रोटीन डाइट वर्क्स वंडर्स एंड रिकवर. सो ये कंडीशंस हैं, DCLD, मेल न्यूट्रिशन, DCLD, portosystemic encephalopathy that can be treated. HCC cannot be treated, but both portosystemic encephalopathy and hepatorenal shutdown, albumin और terlipressin दें, treat हो जाएगा. septicemia treat हो जाएगा. ascites treat हो जाएगी. और एक last case, dengue fever with आया with ascites, और उन्होंने कहा कि जी इसका तो कर दें पित्ते का ऑपरेशन. ये एक कैलकुलस कोलिसिस्टाइटिस है. Or Somia is going to speak about it. I have seen so many people being asked to get cholecystectomy done for dengue-associated gallbladder inflammation. कि ये एक alcoholous cholecystitis है. बुखार हुआ था 2 हफ्ते पहले. वो कोई नहीं पूछता, डेंगू का टेस्ट नहीं कराते और सर्जरी की तरफ धकेल देते हैं. तो फ्लूइड रिसस करें. ये मैंने बता दिया, ये बता दिया. एल्ब्यूमिन इज़ वेरी इंपॉर्टेंट. ऑक्सीजन ज़रूरत है. पेशेंट को सर्वेलेंस की ज़रूरत है. वंस अ पर्सन ऑफ हेपेटाइटिस बी ऑलवेज अ पर्सन विद हेपेटाइटिस बी. ये हम लोग नहीं बताते. मरीज आता है हेपेटाइटिस बी का, आपने कहा था डॉक्टर साहब बीमारी सही है, वायरस जो है ना एक्टिव नहीं है, तो तुसी जाओ हुण मैं आ गया. तो आप देखते हैं तो इतना बड़ा HCC होता है. टेल द पर्सन यू हैव टू गेट एन अल्ट्रासाउंड डन, surveillance done every 4 to 6 months. Every 4 to 6 months you have to spend time with the person. अगर आपने great physician बनना है. This is the last slide. Fortunately, Somia was getting restless, so and thank you for bearing with me. I am going to invite you all on the 4th annual international conference of Pakistan Society of Internal Medicine, which is going to be held in Lahore, PC, 10th, 11th and 12th March. Each one of you is welcome. The registration fee will be made free for everybody who wants to participate. All the residents, PGs, PGRs, medicine ke and allied, jo medicine and allied, will get free accommodation in Lahore during the days, but you have to register with the Professor Muzaffar Sheikh now, so that we can make all the arrangements. All residents of all teaching institutions, whether private or public, will get free registration and free accommodation in Lahore during those days. Thank you very much.
Thank you so much, sir, for enlightening us on a very important subject. And thank you so much for a generous invitation. And inshallah, we'll all definitely be there for the PSIM conference in Lahore as well. Here, I would also like to especially mention LUMHS FM 96.6 and LUMHS TV for broadcasting our program live on radio and television. I hope our virtual audience are enjoying our show just as much as we are sitting over here. Talking about the conditions that threaten our lives and our health, we are going to move on and talk about dengue. For that, please welcome Dr. Soumya Iqtidar, Associate Professor of Medicine, King Edward Medical College, University Lahore, and Chairperson Dengue Expert Advisory Group Punjab, and Secretary General Pakistan Society of Internal Medicine. Can we have a round of applause?
Thank you very much, and special thanks to the organizing committee of this international summit and Professor Muzaffar Ali Sheikh for extending invitation to PSIM and its members for joining us. Ladies and gentlemen, I'm going to talk about a very important aspect of human health today, and that is infections. And when we talk about infections, one infection that has been residing in our country is dengue. Dengue every year causes 400,000 infections, 500,000 hospitalizations, and more than 20,000 deaths. Dengue can be challenging to diagnose. It can affect people with all genders, all ages. Because of air travel, rapid urbanization, and because of this, the dengue has now spread to some of the low transmission areas which were not previously having dengue infection, like southern Florida, Texas, downtown Tokyo, Portugal. And now this has become very challenging because the disease that started from the tropical and subtropical regions has now reached every nook and corner of the country and the globe. Therefore, we are talking today about dengue. So when I talk about dengue, it is a disease of young people. It generally affects the adult population in our part of the world. However, all across the globe, it is usually a pediatric disease. Because of the population growth and the naive population being added, there are a number of patients which are increasing on yearly basis. And there are increasing number of epidemics all across the globe. And as I told you earlier, it has now reached the countries which were previously having low transmission of the disease because of absence of the vector. But because the vector is mobile, now it has crossed borders and it is known as disease without borders. And because of broader geographical distribution, there is increased burden of this disease globally. My name is Dr. Soumya, and I will be talking to you about this small bite, which is a big threat. Ladies and gentlemen, I'm talking about dengue. So dengue is a viral disease. It is a tropical viral infection which is caused by a virus which is known as dengue virus. It belongs to the arbovirus of the Flaviviridae family, and it has 4 distinct serotypes: dengue 1, dengue 2, dengue 3, and dengue 4. This affects humans, and the infection is caused by a vector. And the vector in this case is a mosquito which belongs to the Aedes variety of mosquito. There are many different species of Aedes mosquito, but 2 are responsible for transmission of disease. One is known as Aedes aegypti, and the other one is Aedes albopictus. And this is prevalent, both these species are present in Pakistan and in all parts of the country. With the passage of time, the disease is now being seen in the pediatric population as well. When we started off with the dengue in Pakistan, it was generally an adult disease. But now we have many pediatric patients, and our wards, especially in Punjab in the post-monsoon period, are filled with patients coming with acute febrile illness, and in most of the circumstances, this is dengue. Same is the case with Karachi and Sindh and tropical areas, because the temperature here is moderate all year round, so there are more chances of infection in such conditions, because in very extremes of temperature, that is very high temperature and very low temperature, the disease burden is relatively low. I'm going to give you a definition of diagnosing these patients. This is in accordance with the World Health Organization definitions, but these have been developed by the Dengue Expert Advisory Group in Punjab, which I look after. So the case definitions for dengue fever are 3. We divide them into suspected, probable, and confirmed cases. Suspected cases are those people who present with fever, and the fever has to be of short duration. So it is usually of less than 10 days, and this is an essential criteria to have. And apart from fever, patients can have other symptoms like headache, retroorbital pain, myalgias, arthralgias, severe body aches, bone pains. They can manifest as rash. They can have bleeding in the form of epistaxis, hematemesis, vaginal bleeding, bloody stools, hemoptysis. They can sometimes present with abdominal pain and vomiting, and in some cases we do experience patients having a decreased urinary output, and in children irritability. So if along with fever, any 2 of these, the list that I am telling you, is present, we label these patients as suspected cases of dengue infection. Whenever we come across a suspected case, the next step is to get some lab evidence to support our diagnosis. And the initial test which helps us in making a diagnosis is a simple CBC, full blood count, or a complete blood count test. So if we have thrombocytopenia and leukopenia, that is the drop in the WBC count less than 4,000, or a platelet count of less than 100,000, then we label these patients as probable cases of dengue infection. And whenever we have a diagnosis of a probable case, then we need to confirm our diagnosis. And the confirmatory tests that we use are dependent on the phase of the illness. So if the patient presents to you in the acute viral phase, which is the phase in which the virus is actively replicating in the body and the patient is febrile, we go for the virus testing. So this can be done either by testing the antigen or by PCR testing. But if the patient comes to you after 4 to 5 days, then the phase of viremia is over, and then you check for the antibody response of these patients. The first antibodies that appear are IgM antibodies, and they can be tested in the lab via ELISA method. But in secondary infection, sometimes the IgM response is late, so we check for IgG antibodies in paired samples, which is acute and convalescent samples. And a 4-fold rise in the IgG titers also confirms the evidence that the patient is suffering from acute dengue fever. So every patient has to go through this triad system in which he's suspected first, then he undergoes a CBC and gets a supportive diagnosis of thrombocyto and leukopenia, which makes it a probable case, and then we confirm these cases by having these confirmatory tests. Dengue has a wide spectrum of disease. It can range from an asymptomatic infection to a severe full-blown shock. So the range is very broad. But patients who are of severe dengue, they are known as cases of dengue hemorrhagic fever. And when I use the term hemorrhagic fever, automatically what comes to our mind is the hemorrhage or bleeding. And it looks as if hemorrhage or bleeding is the differentiating point between a simple dengue fever and a dengue hemorrhagic fever. But actually, this is not true. This is actually a misnomer, and this is dengue leak fever, which is the real term which differentiates dengue from a dengue hemorrhagic fever. So in dengue fever, you can also have bleeding, and in dengue hemorrhagic fever, the patient might not be evidently bleeding to you. So hemorrhage or bleeding is not the differentiating point. The differentiating point is the plasma leakage. So if the patient has evidence of plasma leakage, which is manifested either by a rise in the hematocrit, or there is a radiological evidence of leak either via an ultrasound or an X-ray chest, then you have a confirmatory diagnosis of dengue hemorrhagic fever. And if the leak is so severe that the patient develops circulatory failure, which is manifested either by signs of shock that are rapid and weak pulse, tachycardia, narrowing of your pulse pressure, which is the difference between your systolic and diastolic blood pressure, if there is hypotension for age, and if the patients have signs of cold, clammy skin and is restlessness, then this shows that the patient is going into a circulatory failure. And this DHF is now leading to DSS, which is the dengue shock syndrome. So if I talk about the clinical course of the disease, there are 3 phases of infection. The first phase is a febrile phase in which patient has a typical high-grade fever with bone-breaking pains, and patient can have thrombocytopenia and leukopenia along with a generalized feeling of being unwell, loss of appetite. But after the febrile phase is over, there is a defervescence phase, which is the settling of the fever. And this is very important to be very vigilant at that point in time, because these are the patients who can end up in leakage. The dengue infection is serotype specific immunity producing disease. So if one virus attacks you, then the body produces antibodies against it, and you are immune to that particular serotype. But if there is a serotype switch, if in the secondary infection you are bitten by a mosquito which is carrying a virus of another serotype, then you are prone to develop a plasma leakage or a critical phase of the illness, which manifests as dengue hemorrhagic fever. So it is very important that with the settling of the fever, if the patient's condition worsens, and if there are any warning signs, you must rule out plasma leakage by doing an ultrasound of the patient, because this tells you that the patient is of dengue hemorrhagic fever. And after the critical phase, which usually lasts for 48 hours, is over, the patient goes into a recovery or convalescent phase in which the patient starts getting better. So in simple dengue infection, there is usually no critical phase, and the patient straight away goes into a recovery or convalescent phase after the febrile illness, and this is relatively milder form of disease. The febrile phase, as I told you, gives you a typical picture of high-grade fever, flushed skin, body aches and pains. There could be leukopenia, thrombocytopenia, and there could be tender hepatomegaly. In the convalescent phase or recovery phase, the patient feels better, his appetite is regained, and there is appearance of a rash on the body. This rash is pruritic. It is more prominent in palms and soles, and the dermatology book has very beautifully described it in a very poetic manner. They say it is a sea of redness with isles of white pearls. So on the red background, erythematous background of the skin, there are white spots which are itchy. This is the characteristic rash, which is the recovery rash of dengue patients. You can see it in this picture. There is reddish background with white spots on the shin of this patient. Talking about the management of these patients, there are no specific antivirals to date to treat dengue. And dengue is a viral disease, so do not give antibiotics. Because it has a tendency to bleed, we need to avoid non-steroidal anti-inflammatory drugs. We only give paracetamol or acetaminophen to these patients, and that should also be given cautiously, because many a times these patients have transaminitis and liver injury, and paracetamol can be detrimental for them. So you need to be careful. You can give patients any type of diet. There is no diet restriction, but if the patient has vomiting and abdominal discomfort, you give soft diet and you replace the electrolyte solutions. And the most important thing is telling the patient about the warning signs of DHF. The warning signs of leaking should be explained on every OPD visit to the patients, because if we miss out on these signs, then the patient presents to emergency in the form of shock, and once the shock ensues, it is very difficult to take patient out of this condition, and the prognosis is very poor. So these are some of the warning signs which are reported in the literature. The first and most important sign that a patient will tell you is that with the settling of the fever, his condition is not getting better. He would say, I am restless, I have persistent uneasy feeling. When I stand, I have blackouts, I have lethargy. There could be bleeding, or there could be decreased urinary output as well. So please look out for these signs whenever the patient comes to you in the settling phase of the fever, which is known as defervescence. And whenever the patient presents to you with any of these warning signs, or if you have any evidence of plasma leakage radiologically or via rise in the hematocrit, then please refer these patients to in-hospital management. They should be managed in a high dependency units, which is properly equipped with the trained staff to treat these patients. Because in DHF patients, if we monitor these patients for these 48 hours of critical phase judiciously and maintain their intake and output and give adequate amount of resuscitation and blood or dextran wherever required, we can definitely save the life of the patients. So dengue shock syndrome can be a compensated shock or a decompensated shock, which can be leading on to a profound shock. And the mainstay of the treatment, as I told you, is fluid therapy, because there's no specific antiviral to date available to treat this disease. But the fluid therapy has to be very judicious, and it has to be very smooth and uneventful for the recovery of the patient. And the aim is to avoid both shock and overload of the patient. So a calculated amount of fluid is given to these patients. And this is only possible if you monitor your patients by checking their vital signs, their lab parameters, their urine output, and their clinical condition on pre-designed performers on a regular basis. The fluid calculation is done according to the body weight, and for adults more than 50 kg, 4600 ml of fluid is given. This fluid is given in the entire 48 hours of critical phase if you are seeing the patient from the start. But if the patient lands in the emergency or in the hospital in a phase of shock, then the entire 4600 ml can be given over a period of 24 hours. The rate of fluid is via dynamic approach. It is according to the grade of the dengue hemorrhagic fever and the type of fluid that you are giving to the patient and the response to the therapy by the patient in the form of maintaining the blood pressure, the pulse pressure, and the urine output of the patient. The fluid management in dengue shock syndrome is a very wide topic, and I do workshops all across Pakistan and on international forums as well to teach the doctors how to manage these patients. I think this is beyond the scope of this lecture, so I will not touch upon that. But the choice of fluid is also very important in DHF. There are two types of fluid that we use. First is the fluids which are known as crystalloids like normal saline or ringer lactate, which we give as initial resuscitation fluids. But if your patient is not improving and the plasma leakage is worsening, then we have to switch to colloid solutions. The colloid solutions that we normally use are dextran 40 in normal saline, which are hyperoncotic, hyperosmotic fluids, which retain the fluid in the circulation and maintains the blood pressure and circulation. But if your patient is not improving despite resuscitation, always look for ABCS. A is for acidosis, B is for bleeding, C is for calcium, and S is for sugar. Your patient could have been in metabolic acidosis, he could have been bleeding, you need to find occult and overt bleeding. It might be hypocalcemia leading to worsening of the shock, or hypo or hyperglycemia, which needs to be corrected. Whenever you are suspecting a drop in the hemoglobin with deterioration in the clinical signs, please look for internal bleeding. Hematocrit, if it is not as high as expected for the degree of shock to be explained by plasma leakage alone, this also signifies that the patient is bleeding at the same time. So please keep in mind, this is one of the dreadful complications, and you should be treating these patients with blood or packed cell volume. Please note, I said blood and packed cell volumes and not platelet transfusions. Platelet transfusions are no more recommended anywhere in the world for treatment of bleeding in a DHF except in few circumstances. We have this image in mind that since patients' platelet counts are low, so if we increase the platelet count, the patient will stop bleeding or will not bleed, and we should give it prophylactically. This is a misconception which must be dealt and cleared, if not today, in coming few days, by reading the literature by all of you. Platelet count is not the significant factor in bleeding. There are so many other problems which are leading to bleeding in these patients, and they should be kept in mind. And the assumption that the thrombocytopenia causes the risk of bleeding, and if we give platelet transfusion, it will increase platelet count, and the platelet transfusion will decrease the risk of bleeding. These have all been refuted by the medical literature, which are published in big journals like Lancet and Nature, which shows that there is no role of prophylactic platelet transfusion, and platelet transfusion is not the treatment of dengue fever. This is a slide from the courtesy of WHO Collaborating Center in Bangkok, in which I was trained as well. Dr. Siripan is the WHO Collaborating Center head for Southeast Asia region for dengue fever clinical management. I've taken this slide with her permission, that in her center, which is the state-of-the-art center for dengue fever, they give all patients crystalloids. Only 20 to 25% patients need resuscitation with colloids, 10 to 15% need blood, and only 0.4% require platelet transfusion. So this gives you a lot of evidence that what is the role of actually mega units of platelets for which the patients are always running on getting a report of dengue fever. It is of very, very limited use. So I would now summarize my talk here by saying that whenever you have a patient with acute febrile illness with signs and suggestive of acute infection, like without any source of infection, like there are no urinary symptoms or pulmonary symptoms like cough or shortness of breath or abdominal symptoms, please have a high degree of suspicion for dengue. The earlier you diagnose by getting a CBC and confirmatory test, the better your patient will be handled. The close monitoring of the patient and telling the patients about warning signs is of utmost importance if you want to save the life of the patient by not letting them go into shock and preventing the shock. And this timely intervention by giving fluid resuscitation can save life of the patient. From the Dengue Expert Advisory Group Forum, we have published 3 guidelines. The first guidelines were published in 2012 after the first epidemic in Lahore, which has been reported as the world's biggest epidemic. The second dengue CCP guidelines, which are internationally peer-reviewed, were published in 2019. And recently, I've authored the dengue guidelines for pregnancy, which I also presented in the Asia Dengue Summit last year. If you want copies, they are available online. You can download them for free. I have few hard copies with me, which I have placed over here. You can take them for the reference. But as we all say, the most important thing in treating any disease is the communication with the general public. Because I say that dengue is not only a medical problem, it's a social problem. It's the problem because we do not keep our surroundings clean. So it is very important to educate our patients and the community at large about prevention of dengue. Destruction of breeding sites, which are the water collection areas where the mosquitoes grow. Then preventing ourselves from the mosquito bite by not doing outdoor activities during the daytime or dawn and dusk when the mosquito is most active, using mosquito repellents, and vaccination. Now, when I talk about vaccination, this is one question which is put to me on every forum, then when will we have vaccination for dengue? So I will tell you today, when will we have vaccination for dengue? But before I tell you that, there are some myths that I need to dispel. And one of them is, which is deeply rooted in the minds of Pakistani population, is the papaya leaf extract. There will be many people who will be coming to you with this totka of having a papaya leaf extract juice for the cure of dengue. This has been dispelled on non-scientific literature, and there is no conclusive evidence that this is the cure for dengue fever. The papaya leaf extracts contains molecules which do increase the platelet count. I am not refuting it, but increasing the platelet count is not the aim in dengue. Platelet counts will increase with the passage of time on their own, and the credit goes to papaya leaf extract. So discourage the use of papaya leaf extract. It causes severe gastritis, vomiting, and worsens the condition of the patient. The pomegranate juice and apple juice with lemon, this is another myth which has been revolving, and the messages have been floated on the WhatsApp groups for treating patients with juices. Please do not overload your patients with fluids and juices, and particularly red colored juices need to be avoided. The reason for this is that when patient takes a pomegranate juice and then he vomits, he thinks that there is blood in the vomitus, and then he lands up in the emergency. And the doctor is in a fix and the patient is also in a fix, because they don't know whether it is the pomegranate juice in the vomiting or actually he is bleeding. So please discourage juice. Juices are, again, not a cure for dengue. Do not overload your patients with juices. They have nutritional value, but they do not improve the dengue fever. You avoid undue fluids and IV drips. There's no need of giving IV fluids in dengue patients if your patient can take by mouth. And the fluid has to be calculated and not more than 3 to 4 liters, as I told you in the beginning. Ladies and gentlemen, the cost of dengue to society is very much. It not only affects our healthcare system, but the amount of money which the society is paying to treat dengue is about $8 billion. So this is a huge amount. And out of this $8 billion, there are a lot of money which is spent on hospitalization and testing of these patients. And the estimated cost per individual of the dengue case is about $151 on an average. And the dengue costs are greater than any other infectious disease costs like gastroenteritis or cholera or Chagas disease, as estimated by the recent literature. So what is the solution? How can we cut the cost? I think here comes the point when we talk about vaccination for infectious diseases. When the COVID came, we were eagerly looking for a vaccination. And by the grace of God and by the hard work of the scientists, we were able to get a vaccination, an effective and safe vaccination, within a period of a year or so. But for the dengue, we have been struggling for over 5 decades now, and we've not been able to have a successful dengue vaccine in Pakistan to date. But the good news is here. There are now 2 vaccines which are available worldwide. First one is Dengvaxia by Sanofi. It is not registered or approved in Pakistan yet, but it is a WHO-approved vaccine. There's a small setback with that vaccine, that it can be only given to those patients who have had dengue before. So you need a pre-testing and pre-screening for a secondary case. Only then you can give dengue vaccine. There has been a lot of safety issues with this, and there has been a rollout program in some of the countries which launched it in 2019, and now it is no more recommended as a common vaccine to many people. But still, in some countries, it is being used. The countries with a very high endemic burden disease, they use Dengvaxia. The new vaccine which has recently been launched, which is not yet FDA approved, but it is approved by the European Commission, and it is approved by many countries, including Indonesia, which is a very high burden disease area for dengue, is by the name Qdenga. Qdenga is launched by Takeda. They are also trying to launch it in Pakistan. And this is approved by European Union, and it is on the priority list of FDA for approval, according to the news 3 days back. So I will summarize my talk here by saying that dengue is on the rise globally as well as nationally. Dengue has been winning for so many years, and we've been losing precious lives to it. Dengue is here to stay because mosquitoes are here to stay and are not going to go away. And killing mosquitoes has helped us much, but clearing breeding grounds, limiting breeding sites is our responsibility. And now there are newer tools which can have mosquitoes which can no longer spread dengue virus infection. One of these techniques is a Wolbachia technique, which is an organism which is injected into the mosquito, and the mosquito, when it mates with the other mosquitoes, then the future generations are not capable of carrying the virus in them. So this is the technique which is being used globally now in many countries. In around 25 countries, they have successfully running this model, and we are also working in Pakistan to pilot it in Islamabad, the capital of Pakistan. But dengue was also there, but for the last 3 years, we've been talking about only COVID, and it gets very complicated when in the season of dengue, a patient presents with fever, and he has coryzal-like illness as well as symptoms like dengue with thrombocytopenia and WBC count on the lower side. So it gets very complicated. For COVID, we got a vaccine, and this was a very huge success. But with dengue, we've not been successful so far. Qdenga has just been launched. We have to see the post-launch studies of how it affects and how is actually doing in the population rather than in the research trials only. But ladies and gentlemen, there's always light at the end of the tunnel. With the COVID-19, we had a messenger RNA vaccines, which is a newer technology for development of vaccines. And now many companies worldwide are working on this innovative messenger RNA vaccines for dengue, Zika, and chikungunya, which are also spread by the same virus which spreads dengue virus. So there's always hope. I will leave my talk with this message that dengue is our life, our fight, and we should all work together for bringing the burden down, accurately diagnosing our patients and treating our patients. So whoever comes to us with dengue, walking in with the diagnosis of dengue, should walk out as a healthy individual and not as a dead body. This is my mission, and I will carry it forward by training the medical professions all across the world to treat dengue, because now with proper treatment, we can bring down the mortality to actually zero. Thank you.
Thank you so much, Dr. Somia, for a detailed discussion on dengue. I'm sure everybody enjoyed it just as much as we did. Here, I would like to mention that we are joined by our Chairman of Medicine, Professor Imran Ali Sheikh, and I would request him to please join us on stage as he's our chairperson of the session as well. So can we have a round of applause for Professor Imran Ali Sheikh? Thank you so much, sir, for being here. I'm also thankful to other faculty members who have joined us now from LUMHS and also from Muhammad Medical College and Roshan Suleiman Medical College and other faculty members from Nawab Shah. Thank you so much, everybody, for being here with us. We're going to move on with another lecture, which is just as important and common, that is the diabetic foot. To talk about it, we have Dr. Zahid Mia. He's a diabetologist and endocrinologist at Buckeye Medical University, Karachi. Please put your hands together for Dr. Zahid Mia.
Assalamu alaikum. I hope कि दो इतनी शानदार presentation के बाद Somia and Professor Mohsin are champion on talking about anything. So I'm just worried, how can I speak in front of these people. So, but I will try my best to awake you in next 20 or 25 minutes. So, and talking about a problem which we think that it is so simple. And जैसे प्रोफेसर मोहसिन ने कहा कि we are talking about not the patient with diabetes, we are talking about the people with diabetes. And the people of diabetes are increasing day by day. And this is one of the latest number, that 33 million people in Pakistan are having diabetes. And with this 33 million people with diabetes, we are come out to at rank 3 in the entire world. And as the number of people with diabetes are increases, so the complication of diabetes should be increases. And this is, Gust and all get that the demand for the diabetic foot services is increasing. And what we are doing, we're trying to implement and develop sustainable foot care services in Pakistan. Not only in Pakistan, but also in the LMICs, which is the low and the middle income countries around the world. And talking about the Pakistan, 3 million people at present having a foot ulcer. और वो जैसे सर ने खूब शेर व शायरी कही है, तो बात एक छोटी सी बात से शुरू होती है, लेकिन वो कहते हैं ना, बात निकलेगी तो फिर दूर तक जाएगी. तो बिल्कुल यही बात है. The thing start with a small ulcer, with a small scratch. एक छोटा सा ब्लिस्टर, छोटा सा नाखून काट लिया, पेशावरी पहन ली, सलीम शाही पहन ली, खेड़े पहन लिए. स्टार्ट फ्रॉम देयर. एक छोटे से जख्म से स्टार्ट होती है बात. एंड देन जस्ट लुक एट दिस, द इम्पैक्ट ऑफ हैविंग दिस diabetic foot ulcer. This is the paper which we published a few years back, the personal cost of diabetic foot disease in developing world. और एक अगर आप इससे क्लासिफिकेशन से वेल वर्स्ड हैं, तो यूटी क्लासिफिकेशन जो पहले हम यूज़ करते थे, which is the University of Texas classification, और उसका grade 1 ले लें, जो which is a superficial ulcer, just having a skin and subcutaneous tissue involving. So treating that was costing about 3,000 or 4,000 rupees. But with this point of time, treating a 1A ulcer is about 25,000 rupees. And this is the direct cost. The indirect cost was not involved in this one and not calculated. So having a diabetic foot ulcer means cost, problem. And cost और cost के साथ साथ, so every second person with diabetic foot ulcer was found to have depressive symptoms. This is another paper we have published a few years back. And if you look at the amputation rate in Pakistan, we know that the amputation rates in Pakistan are varied from 20 to 40%. But we started in our center an amputation. This is 1996. So we started about 27%. And with the multidisciplinary approach, now at this point of time, we cut down this amputation rate from 27% to only 3%, 3.9% in Karachi, in our center. And if you look at the amputation rate, So the amputation rate, the major amputations, which is of course the BKA and the AKA. So during this period, the number of BKAs and the AKs decreased, cut down enormously, but of course the burden had to be overloaded by the minor amputations. ज़ाहिर है कि जब भी BKs कम होंगे और AK कम अगर होंगे किसी सेंटर में, तो वहाँ पर आप लोगों को अंदाज़ा है कि वहाँ minor amputations बढ़ जाते हैं. And talking about what are the standard of care for treating a patient or a person with diabetic foot ulcer. And these are the guidelines, the International Working Group on Diabetic Foot, published every 4 years. ये 2019 की guidelines हैं और अब next year publish होने जा रही हैं inshallah. And we are the part of these guidelines. And what are the principles of an wound management or an ulcer treatment? So I will not go into the detail of each of this, but will touch a little bit of this. The local wound care, how will we do the local wound care? How will we offload the pressure? What we can do with the infection, of course the diabetic foot infection, and how can we restore the tissue perfusion? And of course, last but not least, is the metabolic control and the treatment of comorbidities. So whenever a person presented to a physician at any level, the wound need to be classified. जो भी wound हो, उसको classify करना ज़रूरी है. Whatever classification you are doing, चाहे वो पहले वैगनर इस्तेमाल होती थी, अब जो है UT classification, and we have done a lot of work on this classification system as well. And now we are doing a Sinbad classification, which बहुत आसान सी classification है. Even the family physician can do this classification. Or us classification, why you are so much interested in doing the classification of diabetic foot infection? Because it led to a pathway of management. Management का pathway आपको बता देता है, और एक referral, not only the management pathway, but also define a referral pathway. कि referral pathway बता देता है. And this is what the Sinbad classification, as the name indicated, Sin, the site, ischemia, neuropathy, the bacterial infection area, and the depth. And you can see the the traffic signal light system as well. So the green is the non-complicated diabetic foot ulcer with a no infection or a mild infection with a score of 0 to 3. A yellow one is the moderately diabetic foot complicated diabetic foot infection with a score of 4 to 6, and the red one is a severely complicated diabetic foot ulcer with a score of 6 and above. And for the management of diabetic foot ulcer, what you need to do is we need to examine and assess an ulcer by a trained professional. And training, जो जैसे कि अभी बातचीत हुई कि ट्रेनिंग इम्पॉर्टेंट है, चाहे वो आप किसी भी एस्पेक्ट में करें, कार्डियोलॉजी की ट्रेनिंग ले लें, फुट अल्सर की ट्रेनिंग ले लें. ट्रेनिंग के लिए ज़रूरी है कि आप जैसे कि पोडियाट्रिस्ट है तो उसे ये तो पता होना चाहिए कि पता हो कि स्कैल्पल किस तरह का होगा, कैलस किस तरह रिमूव करेंगे, प्रेशर किस तरह ऑफलोड करेंगे. So they need to be trained. And for this training, what we have done up till now, we have trained 448 family physicians in the diploma in diabetes who are working across the Pakistan. And the worldwide, we also know that there is a worldwide lack of recognized podiatry facilities. And only 18 countries in the entire world have got this podiatry services. आपको पता है कि पोडियाट्री पूरा एक सब्जेक्ट है, उसमें 4 साल जो है वो लगाना पड़ते हैं, और उस 4 साल के बाद भी पाकिस्तान में लोग समझते हैं कि है तो ये पट्टी वाला, रहेगा तो ये पट्टी ही वाला. सो दैट इज़ एंटायर डिफरेंट कॉन्सेप्ट. और जो यूरोपियन कंट्रीज़ एंड US है, वहाँ पर इसका एक फैकल्टी है. सो because we don't have these podiatric services, so in 2000, I think this was 8, when we, in a meeting with the IDF consultative section with the diabetic foot, we have planned that we need to have a diabetic foot education program in the countries who do not have a podiatric services. जहाँ पर podiatric services नहीं है, 18 ममालिक के अलावा कहीं नहीं है, तो वहाँ पर ये होना चाहिए. So what we have done this course for the 6 weeks course of the diabetic foot care assistants, and up till now, what we have done, we have trained about 154 diabetic foot care assistants. And then we need to train the people, the person, the family physician in the diabetic foot as well. So we have developed this diabetic foot training course for the family physician, and up till now, the 150 healthcare professionals have been trained into this 6-week course in the diabetic foot care systems. And on the national, there is a national diabetic foot advisory board meeting, and we met at every Wednesday at 9 a.m. और ये वर्चुअल मीटिंग है, इसमें पूरे पाकिस्तान से लोग आ सकते हैं, आप भी आ सकते हैं इसमें और कनेक्ट हो सकते हैं, एंड यू कैन डिस्कस whatever case you wanted to discuss and take advice from the people who are expert on this line. And these are some pictures from the different centers. ये इस्लामाबाद के centers से हैं, and वो save the limbs and the life of the people with the diabetic foot problems. So Pindi, Jamshoro, Islamabad, Multan, and Lahore, Hyderabad. And then what we have done is that this is the home visit by the DFCAs, and so the hospital at home. And there is a paper which was published a few years back which suggests that there is a reduction of about 21% mortality and 24% reduction in readmission on this aspect. So the diabetic foot care assistant can take an advice जब वो घर पे जाता है पट्टी करने के लिए, तो वो एडवाइस कंसल्टेंट से डायरेक्ट ले सकता है कि मैं इसके साथ क्या करूं. एंड सिमिलरली द पेशेंट कैन टेक एडवाइस बाय यूजिंग द टेक्नोलॉजी, एंड दे कैन connect with us on the WhatsApps as well. And this is the new aspect, which is the point project of the DFoot International. And we are going to launch this podiatric skill development program in Pakistan in the next year, inshallah. So the next step in the managing of diabetic foot ulcer is the offloading. Offloading an ulcer. Plantar foot ulcer, जब तक के offload ना किया जाए, तो वो सालों नहीं बढ़ता. Many years you can have them over there, but you cannot heal them if they are not offloaded. So there are many techniques of offloading, and this is one of the gold standard technique, which is called the total contact cost. Total contact cost से आप कर सकते हैं. Now we have readily available techniques, which is the air cast boot. पाकिस्तान में भी अब आ चुके हैं, और इनको आप दे के जो है वो offload कर सकते हैं. We have published this paper in 2012, I think, that the use of locally made technology. इसमें हमने क्या करा कि modified, वो जो सैंडल होते हैं, पेशेंट जो सैंडल पहना हुआ होता है, आम से सैंडल, उनको modified किया और उसको फिर कंपेयर किया प्लास्टर ऑफ पेरिस कास्ट से एंड स्कॉच कास्ट बोर्ड. एंड व्हाट वी हैव सीन दैट the healing rate remains the same of the three technology, but the cost is entirely different. तो जो फुटवेयर जो हम मॉडिफाइड करते हैं, मरीज़ का जो मॉडिफाइड करते हैं, उसकी कॉस्ट कहीं कम है as compared to the modified plaster of Paris cast or the Scotch cast put. So, and this is what the paper is telling about. And then we have seen those people who do not have जिनको अभी अल्सर नहीं हुआ है, and they are having a higher risk of developing ulcer. So this was the paper, the 18,000 people with diabetes का ये paper है. और इसमें वो लोग जिनको अभी they don't have the ulcer yet, but they are going to develop, they may develop the ulcer, that is the people at risk of developing ulcer. And just look at what we are doing, what the people are doing. And अगर आप देखें इसमें तो daily inspection of the feet, about 78% of the people with diabetes do not inspect their feet daily. 80% लोग, प्रॉपर 70% लोगों को नेल काटना नहीं आता कि नेल कैसे काटना चाहिए, सीधा काटना चाहिए, कॉर्नर नहीं काटना चाहिए. इसी तरह लुक एट द फुटवेयर. 90% of the people do not know what is a proper footwear. By the way, most of the physicians don't know what is the proper footwear for the diabetic people with the diabetes. And then the barefoot walking, 60%. ये क्योंकि शहर में की गई थी तो 60% है. अगर इसको ज़रा सा पेरीफीज में ले जाएं तो ये उससे भी ज़्यादा निकल जाएगा. Barefoot walking, 60% barefoot walking है. And the people who have neuropathy, then you can just imagine how easily to develop a foot ulcer. And for 90% of the people who do not know what is the right footwear for them, so we did a project which was called the footwear for the every diabetic. ये हमने फिर 10 प्रोजेक्ट सेंटर पूरे पाकिस्तान में बनाए. एंड देन इसमें रिस्क असेसमेंट क्लिनिक्स हैं, उसमें अवेयरनेस अबाउट द डायबिटिक फुट, एंड a trained person from the Denmark comes for training or the trainer program किया. And we just pick up the street cobbler. हमने cobblers को उठाया, street cobblers को फिर ये ट्रेन किया कि हाउ टू मेक, और ये जो फुटवेयर हैं किस तरह बनाए जाएं. और उसी के साथ उनको DFCA जो हैं हमारे डायबिटिक फुट केयर असिस्टेंट, उनको भी ट्रेन किया. एंड दीज आर द फुटवेयर. ये वो फुटवेयर हैं जो पाकिस्तान में ही बनते हैं. ये कोई बाहर बने हुए नहीं हैं, ये पाकिस्तान में हमारे ही सेंटर में बने हुए फुटवेयर हैं. And we have presented this data in the great consultative meeting in the WHO and in the DFC con as well. And you will be surprised to know कि ये तकरीबन 1,51,000 लोगों का डेटा है. 1,51,000 लोगों का डेटा है. और इसमें अगर आप देखें तो 2 ग्रुप हैं. एक वो ग्रुप है जिनको अभी ज़ख़म नहीं हुआ है, दैट इज़ दे आर एट रिस्क ऑफ हैविंग अल्सर, उनको अभी ज़ख़म नहीं हुआ है. एक वो लोग हैं, और दूसरे वो लोग हैं जिनको डायबिटिक फुट अल्सर है. सो अगर आप उस ग्रुप को देखें जिनको अभी ज़ख़म नहीं हुआ है और उनको हमने ये प्रोटेक्टिव फुटवेयर दिए, तो ओनली 3.7% लोगों को डेवलप देयर फर्स्ट और रिकरेंट अल्सर. Only 3.7. And mind you that there is no data regarding the prevention of first ulcer in entire world. अभी तक कोई data नहीं है. This is data in publication now. So this is a big achievement. Is this in this part of the world? And then we have the other group in which we have shown that about 70% of the people who use this footwear, modified footwear, have got more ulcer healing rate as compared to those who do not. And this is what the WDF, the World Diabetes Foundation, the footwear for every diabetic protects feet across the Pakistan. And then the third aspect, I will take only 5 minutes now. So the third aspect of the important, one of the most important thing is the diabetic foot infection. और जैसे कि प्रोफेसर साहब ने बताया कि इन्फेक्शन में जो सबसे बड़ा मसला हमारे साथ है वो हाफ हार्टेड ट्रीटमेंट है. ये जो क्लिंडामाइसिन 200 मिलीग्राम 300 मिलीग्राम ट्वाइस डेली, सो ये जो डोज है और फिर 4 दिन के लिए दे दी, 3 दिन के लिए दे दी, मरीज़ ने खुद बंद कर ली. आपने कहा 6 घंटे बाद खाना है, मरीज़ ने कहा 2 घंटे, मैं तो सिर्फ 2 दफ़ा खाऊंगा. सो दिस मेक्स द प्रॉब्लम मोर वर्स. And more than half of the diabetic foot ulcer are clinically infected at the time of presentation. This is the worldwide. But look at our data. This is our data. About 78% of the foot people who presented to our clinic are infected. And about 40% of them having an osteomyelitis. 40% of them having an osteomyelitis. And this is the data from Vijay from Chennai, which shows that about 90% of the people with diabetic foot ulcer having an infection, the cause of amputation is infection. The cause of amputation is infection. And similarly, we have the same data, about 88% of our patients, the cause of amputation is infection. So there are many classification. One of this is IWGDF or IDSA classification. I'm not going into the detail of this, mild, moderate, and severe. कुछ हुआ क्या? मैंने गलत बोल दिया कुछ? भाई माफ कर दो. अब नहीं कहूँगा. अच्छा, कुछ तो कर दो. टाइम पूरा लूंगा अगर तुमने बंद भी कर दी तो. ओके. नहीं नहीं वीडियो नहीं. दिस इज नॉट वीडियो. ओके, तो अगर टाइम शॉर्ट हो रहा है तो इसलिए बंद कीजिए तो वो अलग बात है, लेकिन अब ठीक है कोई बात. So why we need to classify the ulcer? असल बात तो ये है, why we are creating so much to classify this foot infection as well. Foot infection is has got the worst prognostic. Moderate to severe infection की prognosis सबसे खराब है. वो patient जो कि severe infection के साथ हैं, 70% of them having an amputation and hospitalization. That is why we are saying that you need to classify the infection as well. And एक और बात जो important बात है, you need to have your own local data regarding the what type of infection you are having. कौन से infection आपके पास हैं, और वो infection हमारे पास रेजिस्टेंस, जैसे सर ने कहा कि रेजिस्टेंट ऑर्गेनिज्म बहुत ज़्यादा हैं, और हमारे पास सूडोमोनास है, इसके बाद MRSA है, and there are so much resistance. We have got MRSA about 25%. We have Pseudomonas resistance about 27%. So अगर ये resistant pattern आएगा, और उसकी reason सिर्फ वही है कि एंटीबायोटिक का यूज़, इनएडवेंट यूज़, उसकी कम डोज, उसकी कम ड्यूरेशन, जल्दी बंद कर देना, सही से नहीं देना, कॉम्बिनेशन सही ना हो, तो दिस इज़ व्हाट वी आर टॉकिंग अबाउट. सो these are the MDR, and MDR का मतलब आप समझते हैं कि 3 लाइफ of drugs जो है वो आपकी बेकार हो गई, जो कि कॉमन ड्रग्स हैं. कॉमन ड्रग्स ख़त्म होने का मतलब, जैसे सर कह रहे थे कि अब आपके पास मीरो रह गया, टीको रह गया, वेनको रह गया. एंड मीरो, टीको, वेनको यूज़ करने का मतलब है तकरीबन 5,000 रुपये पर डे ओनली on antibiotics, only on antibiotics. So, and this is what we have presented, that the 40% of them had osteomyelitis as well. And the last part of this talk is the restoration of perfusion. And I'm only showing this data that we have done in our center. 60% of the angioplasties, with the angioplasty we have saved the major amputations. And delay in referral is one of the high amputation, cause of the high amputation rates. And this is very common, not only in Pakistan, but बाकी ममालिक में भी बहुत common है. And this is what the fast track program, which reflect the recent recommendation of DFOOD International and direct the management and referral based on the severity of the patient, ulcer and existing comorbidities. And we have shown the effectiveness of this fast track program, that those who utilize this fast track program, fast track का मतलब है early referral जिन्होंने कर दिया, उनकी mortality भी कम हो गई और उनका ulcer healing rate भी कम हो गया. And we have launched this fast track program in Pakistan with an aim of reduce avoidable amputations across the Pakistan, and the provision of evidence-based standard of care to the people with diabetes within or their vicinity. And we are making connection between the primary, secondary and the tertiary care people. अगर आपके पास किसी भी level पे patient आ जाए, they has to be referred back to that particular physician at whatever level he is working. And we have now established about 118 diabetic foot clinics in all over the Pakistan. 118 in this year, and in next year, inshallah, we are going to develop more, about 300 clinics, more clinics in Pakistan. And what we need to develop is, we have developed a mobile app. अभी क्योंकि time कम है तो इसकी detail में नहीं बता सकता, but to collect the data, we have developed a mobile app, and we have a roadmap. So if you wanted to have a standard of foot care management, you need to have a team training, a data collection, a referral system, and then you need to have a standard of care. And last slide, this is the foot practices in people with diabetes, where we do stand. ये भी कुछ साल पहले का है, और इसको देखते हुए मुझे ये लगता है कि we need to have, क्योंकि इसमें अभी हम बहुत दूर हैं उस standard of care से जहाँ पर होना चाहिए हमारे patient भी. So what we think that my work is not yet done, and we need to have a lot of work need to be done. And the time for action is now. It is never too late to do something. Thank you very much for your patient listening.
Thank you so much, Dr. Zahid Mia, for a wonderful talk on diabetic foot. With this, I would like to once again thank all of our speakers for wonderful talk on such important topics, and it's time that we put these words into action in our clinical practice. With this, we move on with the shield distribution ceremony, and we would like to offer shields to our speakers as a token of gratitude. For that, I would request the organizer of this session, Professor Muzaffar Ali Sheikh, to escort Dean of Medicine and Chair Organizing Committee, Professor Muin Ansari, on stage for distribution of mementos. I think Professor Muin Ansari had to be somewhere, so he has just left. So we are going to do the distribution of shields by Professor Muzaffar Ali Sheikh. To present the shields to the speakers, I would request Professor Aftab Mohsen to kindly come on the stage and receive his memento. And now I would request Dr. Somya Iqtidar to please come on this stage and accept her shield. And now I would request Dr. Zahid Mia to please come on this stage and accept his shield. Can we have a round of applause, please? Next up is our honorable panelists. I would request Professor Khalid Mahmood Khan to please accept his shield. And now I would request Professor Zaman Sheikh to please accept the shield. And now I would request Professor Noor Muhammad Memon to please accept the shield. It is wonderful having Professor Noor Muhammad Memon amongst us. He's a teacher of teachers. He's remained teacher of all of us sitting over here. So a big round of applause for Professor Noor Muhammad Memon. And now I would request Professor Muhammad Iqbal Shah to kindly receive the shield. And now I request Professor Muhammad Iqbal Shah to kindly receive the shield from Professor Muzaffar Ali Sheikh. And now I would request Professor Aftab Mohsen to please join us on this stage and present the shield to Professor Muzaffar Ali Sheikh. I would request Professor Aftab Mohsin to kindly remain on the stage as we distribute shields amongst the chairpersons as well. I would request Professor Shoaib Ansari to please accept the shield. Now I would request Professor Khalid Sheikh to please accept his shield. Professor Abdul Haq, sir, you are requested to please accept the shield as well. A round of applause, please. I request Professor Naila Masood to kindly accept the shield. And now to accept the shield, I would request Professor Mukhtiar Jafri to please come forward. And before accepting the shield myself, I must say how great of an honor it is for me to be sharing this stage with all of my teachers that I have learned so much from. So thank you so much. I thank you all once again for being with us, and with this we conclude our session, and I request all of you to please remain seated as the next session is going to start now. So thank you so much and have a nice day.
Hello, hello. All the participants, delegates are requested to please be seated. We will be starting next session in 2 minutes. Hello. Ladies and gentlemen, please be seated. We are starting our first plenary session. All the respected delegates, organizers, and the participants are requested to please take their seat. We are about to start.
Hello, hello. Hello, check this. Hello. Hello, hello, hello.
Ladies and gentlemen, please be seated. The session is about to start.
Hello, 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 hello. Hello, hello. Hello. Hello, hello, hello.
Good afternoon, ladies and gentlemen. We are gathered here today at the first plenary session of the International Academics and Research Summit LUMHS 2022. I welcome you all to this International Academics and Research Summit LUMHS, which is being organized at Liaquat University of Medical and Health Sciences from 16 to 18 December 2022. The theme of the summit is integrating healthcare delivery with sustainable development goals. The summit is being organized with the key objective in mind to inculcate importance of sustainable development goals among the health professionals on a platform to explore the new avenues of the integration of SDGs into the existing healthcare system. An alliance to establish with all the stakeholders in order to develop a broader and a stronger framework leading to the state-of-art provision of services, academics, excellence, and research culture. Proceeding towards our session, I would like to introduce the panelists for today's session. Our first panelist for today is Professor Dr. Asif Birni. Professor Dr. Asif Birni is a professor of medicine and Vice Dean Faculty of Medicine and Allied Sciences at ISRA University Hospital. I would request Professor Asif Birni to please come on the stage. The next panelist we have is a legendary surgeon who has produced a number of surgeons and contributed in the field a lot. and the name is none other than Professor Dr. Abdul Sattar Memon Saab. Professor Abdul Sattar Memon Saab is a professor of surgery, formerly served at Liaquat University of Medical and Health Sciences, and currently is providing his services at ISRA University, Hyderabad. The next panelist we have is Professor Dr. Feroz Ali Kalhodo. Professor Dr. Feroz Ali Kalhodo is Professor of Dentistry, Dean, Faculty of Dentistry at Liaquat University of Medical and Health Sciences, Jamshoro. The next panelist I would like to invite is Professor Dr. Ashok Kumar Narsani. Professor Ashok is Professor of Ophthalmology and currently looking after the Office of Dean, Faculty of Surgery and Allied Sciences. Moving towards the plenary talks, I would request Professor Dr. Abdul Razak Sheikh. Professor Abdul Razak Sheikh is Professor of Surgery and currently serving as Registrar, College of Physician and Surgeon, Pakistan.
अस्सलाम वालेकुम। अच्छा इधर माइक नहीं है, इधर कुछ हाँ हाँ। Actually, it is a great honor for me to be here. I've served here as a faculty member, as a Dean of Surgery when I retired more than 25 years at Liaquat Medical University. So really it's a very honor for me to have a speaker, guest speaker here. And it is a very honor for me. And actually, my presentation is about some laparoscopic training, which I conducted a study for my MCPS HP at Karachi, CPSP. So I would like to start, sorry. First of all, we would like to have some introduction, global health problem, because of the theme of the conference. I have included some topics. Simulation history, simulation in laparoscopic surgery, and my own study if I find some time, and then the conclusion. These surgical skills were traditionally taught with operation theater, with a mentor apprenticeship model. And this is more than 100 years old model, which was being followed in many institutes, still today, what we find. And the trainees are trained in the operation theater on live patients. So they learn on live patients, which is not a risk-free. Sorry. This is a Holstedian model, see one, do one, teach one. This is no longer valid. What are the drivers for change? Everything has changed in this century. The public's expectations, the public have become more knowledgeable, more access to the internet. They know about everything. So you can't hide anything, any complication, anything, and they expect to be safe and free. So that's why it's very important. And then definitely the treatment of all the diseases changed. First we used to do the laparoscopic open cholecystectomy for gallstone, then lap chole, 4 ports, 3 ports, 2 ports, 1 port, no ports, cells, and then the robotic surgery, and then the tele-robotic surgery. So sky is not the limit. Everything is changing, and people are expecting the most modern way. But you have to be competent first and then operate upon those procedures. Don't make a practice on live patient. Definitely, many practices have changed in surgery. Lot of things that used to be operated by surgery are now operated by non-surgically. You have to think about all these procedures. And then the technological advancement. Lot of machines, lot of things have been produced in the market. And you have to operate, definitely you have to know the know-how, how to deal with these machines, and definitely then you can operate. And reduction in training time. Of course, there's the doctors, they want that the time working hours should be reduced to maybe 8 hours per day. So the time is reduced. When we used to be postgraduates, I've done my fellowship in 2 years. Now it's up to 4 years and 5 years in FCPS. It's not that we were smart, but because of the expectations, the things have become more complicated, the diseases have become more complicated. And definitely the people are expecting too much from you. The courage does not compensate for the lack of ability. You have to be very competent. What do patients want? Why the laparoscopic surgery? Patient wants a small scar, less hospital stay, less pain, faster recovery, and of course the very competent surgeon. I've put this slide only because of the theme that when we are impacting the global health, we have to look for all these factors. Especially when we are looking for the aging population and then the new machines and then the financial aspect. One thing that I would like to say, then we say that there's a high mortality, neonatal morbidity, mortality, maternal mortality is high in some hospitals. Then we say that doctors are not competent. It's not so. Doctors are competent. It's the health is not inside the stakeholder. Health is outside the stakeholder. I mean to say, it is the strategic planning of the government which gives them the access. If they are not giving the safe water, safe food, and the environments, definitely the doctors can't do anything. So it is the outside, and then definitely the health stakes are very much involved. If they don't provide you the instrument, the facilities of training, say, I've seen as a registrar that some university at Sindh, they did not take any postgraduate last 6 months. Problems are workforce shortage, cost of training, duration of training has increased, patient safety issue, higher education costs. So what we need to train them, give them the chance to train, and give them the safe environment to train. 28 to 32% of the global burden of disease can be attributed. So 1/3 is surgical. The Lancet Commission in 2015 said there are 5 billion people with no access and affordable surgery. We want that health should be equitable. There is no distributive justice. It should be equally distributed for a patient in Karachi and patient in Mirpur Khas. It is not so. The maximum health facilities in Sindh, I'm not going to be very politically, but it's very true. Most of the health facilities in Karachi, and our fellows are in Karachi, and least in 2.2 billion surgeons are required, 143 million additional operations every year. Current system is not working. So what should we do? Think of what we want and then we create it. Change the DNA of healthcare. This is must. Disruption of the medical education using power of internet technology, develop a new training model. Change the way we selected and educated the surgeons. What is solution? Solution is technology to improve safety, surgical simulation to offer, immersive learning experience, which is safe, effective, and fast. Learning pyramid, as you know from this chart, that maximally we don't only learn 5% from the lectures, and 90% while with it teach others and practice 75%. So you have to adopt those methods. Industrial revolutions. There are 4 revolutions, first, second, third, fourth. As you can say, I will talk about this one, 4th industrial revolution, which nowadays it's there. Genomics, nanobiotechnology, virtual reality, augmented reality, artificial intelligence, robotics, big data, and wearable sensors. I may not touch upon every topic, but I will talk about more about simulation than surgical simulation and technology. Benefits of surgical simulation, what are those? Provides standard and effective training simulation to the post-trainees. Validated transfer of skill from operation theater to the training facility, to the operation theater, and to the patient care. Definitely the patient who are operated after training are better outcomes. It is validated by the studies. Objective measurement of the performance. It's not subjective. We may improve what we measure. If we cannot measure what we think, that we cannot improve. We have to be objective. We don't have to be conscious bias or unconscious biased. We have to think about be objective than subjective. Novice risk-free practice, they can practice it anywhere, not in the laboratory, on mobile phones they can practice the things. That's very best. With their own time, with own schedule, this is not a classroom they can have. And this is something student-centered learning. This is not adult type of learning. This is most modern way. Cost-effective alternate to human cadavers, animals, no cadavers, no dissection, nothing. Definitely, we need in laparoscopy, this is 2D, long instruments, hand-eye coordination, depth perception, limited access, and bimanual. These are the main problems and limitations. What we need, laparoscopic learning curve for practice, repetition, and time. When we train the postgraduates, we go ask them to practice for 8 hours. It is in limited, in distributed practice, what we say. If there is some limited time, stress we can have it for the trainees. After that time, the learning declines. So you have to think about all these factors. This is what we say. The person starts with a novice who is very unconscious, that he does not know. He begins and he is conscious that he does not know. And then he starts training. Advanced is when he becomes competent, and unconscious expert. This is 4th stage. I will not touch upon these psychomotor skills. These are the 5 steps that when we teach a psychomotor skill. Then we have got conceptualization, visualization, verbalization, practice reinforcement, skill mastery. Something very important is the feedback is very much important. And in simulation we say debriefing, which takes more time than the skill. This is the old models, box trainers, cadavers. Simulation is a technique to replace or amplify the real experiences with guided experiences, often immersive in nature, that evoke or replicate the aspects of real world. That is David Gaba. It's a technique, it's not a technology. Many of the tools, they are technology. Moore's law says that the computing power doubles every 18 months. So we can have so much knowledge due to technology that we cannot cope with it. A surgeon trained on simulators is twice as fast and twice as accurate. One who has not been reduces error, making surgery much safer. History. Many great ideas are ignored and dismissed, only to be recovered at later time with better understanding and acceptance. One training simulation, you know the high risk industries like airways, surgeries also have this profession. One training simulator for every 300 pilots, one training simulator for every 7,300 doctors. This is for UK, not Pakistani figures. These are some classification. I would touch upon few topics. Part toss trainer, full body simulator. Virtual reality, real people as simulators. We have got now the cyber patients, digital patients, screen created patients. So we don't need the real patients as simulator now. Hybrid simulation and simulated environments. And these are the all things that different times research any. This is the mask of the girl with the failed romance floating dead body in a river, and that face was preserved for resuscitation. It is very famous in the history of the simulation research any. Mannequin best, operating room second life. We have got, these are very costly. So when I've been trained at Indus Hospital, Karachi, they developed these low-cost simulators. Pulse oximeter, priapism for eye, and these all, even for bone and these. This is a virtual research room. I will not go details. This is what we say, that you have got the scenario, then you have to monitor the patient, some drugs, and this give you the feedback. This is very much artificial. ये नहीं चल रही. Some scenarios are, simulations are scenario based. In emergency, in operation theater, you think of who is the leader. Some nurse, some doctor, and definitely. I think ये आवाज का कुछ करो अगर हो सके तो. माइक रखो. नहीं आ रही आवाज. इसको बेहतर करें, चलें. हो जाएगा आवाज, करें. नहीं आ रहा. I'm sorry. So this is a new virtual reality. We are no longer performing surgery training on this old version. This is new version. We have